Hi everyone and welcome. Thank you for joining this tutorial on the episode-oriented electronic health record based on Solon's concept of the episode of care. In everyday practice, patients follow a care pathway across inpatient and outpatient care. The challenge is to structure the record so the clinical course is easy to follow, traceable, and supports continuity of care. Today I will introduce the core idea of an episode of care. My goal is to keep this practical and easy to follow. We will start with a short introduction and then we will build the episode step by step using a concrete clinical example. So let's get started. Before we talk about episodes of care, let's zoom out for a moment. What do we actually mean when we say an electronic health record? For each patient, an EHR is created as a container for clinical information. Over time, different healthcare professionals add data to it. The record grows along a timeline. It contains two complementary parts. One part is observations and facts, such as symptoms, findings, lab results, imaging, medication, and reports. The other part is the clinical assessment, including interpretations, problems diagnosis, and clinical reasoning. In daily practice, documentation has to be quick and complete. The aim is to capture what matters without slowing down care. But storage is only half of the job. The other half is making the information easy to find, easy to understand, and clinically useful. The EHR should also support secondary use, for example, quality improvement, analytics, and research. This is why the data should be stored as structured content, not only as free text. Wherever possible, it should also be coded and linked to standard terminologies such as ECD, SNOMED, CT, or LOINC. Structured and coded data can then be used for clinical views, handovers, decision support, and AI. So the question is not only what is documented, it is also how is it organized so it makes sense across the whole care pathway. How can information be organized? A common first step is to organize the record into clinical sections. These are familiar headings from clinical training. They match how clinicians think, read, and document in daily practice. These sections are grouped into main categories such as medical history, physical examination, diagnostics, therapy, and clinical notes. Each category contains a set of more specific sections. Clinical sections provide internal order. They make it faster to find information and they support communication and handover. Another helpful distinction is between the medical record in a narrow sense and in a broader sense. In the narrow sense, the record contains two main types of data. First, there is persistent data. This is the patient's medical master data. It is relatively stable over time and only updated occasionally, for example, past medical history, allergies, and family history. Second, there are event-based entries. These are documented along the time axis, for example, the history of the presenting complaint, the physical examination, and progress notes. This separation improves clarity. However, it still does not connect information across encounters and settings. For that, an additional higher-level organization principle is needed. This brings us to higher-level organization of the EHR. There are several established approaches. One approach is document-oriented organization. where information is mainly grouped by documents such as reports or letters. Another is source-oriented organization, where data is grouped by the producer, for example radiology, laboratory, or a specialty service. A third approach is consultation-oriented organization, where entries are grouped by encounters or visits. A very influential method is the problem-oriented medical record described by Weed. It structures documentation around a problem list and problem-focused entries. Finally, there is the episode-oriented approach described by Solon. This is the most demanding form of high-level organization because it links information across time and across settings into one current clinical course. Importantly, the other approaches can still be represented within an episode-oriented design. Documents, sources, and consultations do not disappear. They become views or groupings inside the episode framework. This is why the episode of care is such a powerful organizing concept and why we will focus on it in this tutorial. Now we move to the core concept, the episode of care. We will build it step by step using a concrete clinical example. This is Emma Brown. She is a 62-year-old woman. Miss Brown is traveling by train from London to Oxford. On the train, she meets Mr. Jones. Mr. Brown sneezes. Miss Brown is exposed to the influenza virus. A few days later, Miss Brown falls ill. Miss Brown visits her general practitioner, Dr. Smith. Dr. Smith takes Miss Brown's history, examines her, and starts treatment. Then Dr. Smith documents everything in Miss Brown's patient record. 3 days later, Miss Brown returns to her GP. After further 3 days, Miss Brown calls to report improvement. After 8 days, she has fully recovered. Let's summarize the case on a timeline. First, Miss Brown is infected. A few days later, she develops symptoms. She then visits her GP. A second consultation follows. 3 days later, she reports improvement by phone. 2 days later, she has fully recovered. So, this is one health problem managed through 3 care encounters with her GP. How can this care pathway be structured in the record? There are 3 different ways to organize it. It can be structured by time, by organizational context, or by clinical content. One way to structure the care pathway is by time. This is the temporal dimension called a period of care. A period of care groups together all care and treatment delivered within a defined time window. It does not necessarily describe one clinical problem, it is simply a time frame. For example, Dr. Smith invoices all services provided from 15th to 17th February. The second way to structure the care pathway is by organization. This is the organizational dimension using the care encounter. In Solon's methodology, this is referred to as a contact. In our example, there are 3 such contacts with the GP. A contact is an interaction between a patient and a healthcare professional at a specific time and place. For example, Ms. Brown and Dr. Smith have an appointment for a consultation on 20th February at 8:15 a.m. There are different types of contact or care encounter. They can be face-to-face, such as a consultation, a home visit, or ward round. They can also be remote or indirect, such as a telephone consultation or a file review. The content structure of a care pathway is an episode centered on exactly one specific health problem. An episode has a clear beginning and a clear end. For example, Ms. Brown has the flu as a health problem. The illness starts, runs its course, and then resolves. That makes it a distinct episode. Depending on the perspective, an episode can be defined in different ways. An episode of illness focuses on how the patient feels and what they experience. It starts when well-being is affected and symptoms begin. It ends with recovery, incomplete recovery, or in some cases death. In our example, Ms. Brown starts to feel cold and her nose begins to run. Later, she feels well again and goes back to work. Another perspective is the episode of disease. The episode of disease describes the same illness, but from a clinical and scientific perspective. It uses medical criteria such as pathophysiology. In our example, Ms. Brown is infected with the influenza virus. The incubation period is typically 1 to 2 days. Finally, the episode of care brings in the healthcare perspective. An episode of care includes one or more contacts with healthcare professionals to manage one specific health problem. All clinical information related to that problem is linked to the episode. In our example, Ms. Brown has 3 contacts with Dr. Smith for the treatment of the flu. An episode of care is named after the underlying health problem. In our example, at first contact the episode is labeled fever. At that point, it is a working problem description. At the second contact, the label is updated to flu once the clinical picture is clearer. So the episode name can be a problem description or a diagnosis. The most recent label becomes the current name of the episode. Earlier contacts keep the label that was used at the time, so the historical record remains unchanged. Each episode of care has a status. It can be active or resolved. An episode of care starts with the first contact with a healthcare provider. At that point, the status is active. It ends with the last contact related to that problem. The episode is then marked as resolved. Chronic episodes of care are different. They remain active and are not truly resolved. A patient can have several health problems at the same time. In an episode-oriented record, one episode is created for each health problem. Complications are handled in the same way. If a complication becomes a distinct problem, it is recorded as a separate episode. For example, Ms. Brown has diabetes mellitus, the flu, and a urinary tract infection. Each of these health problems is a separate episode of care. Let's summarize what we have covered so far. Care pathways can be structured by organization, time, or content. First, the organizational dimension. A contact or care encounter is a single interaction with a healthcare professional, for example, a consultation or a home visit. Second, the temporal dimension. A period of care groups all treatments within a defined time frame, such as a day, a week, or a month. Third, the content dimension. The episode of care links all contacts and clinical information for the treatment of one specific health problem. What exactly happens at the contact or care encounter? Let's remember what happens at the first contact in our example. Dr. Smith takes Miss Brown's history, examines her, and starts treatment. He then documents the consultation in her patient record. So there are two parts. First, the clinician's actions. Second, the documentation of the clinical findings. In our example, the clinician's actions include history taking, physical examination, a throat swab is taken as a laboratory test. Finally, treatment is started with a prescription. The clinician then documents the findings in the electronic health record. Fever is recorded in the medical history and as a finding on physical examination. The lab result is documented and the prescription drug is recorded under treatment. Each of these items is stored as a separate medical record entry in the EHR. How can these medical record entries be grouped? Each medical record entry is linked to a clinical section. Clinical sections are the familiar headings used in day-to-day documentation. For example, an entry can belong to the medical history, the physical examination, or diagnostics and investigations. Medical record entries within the same clinical section automatically form a clinically meaningful unit. So, the primary structure of the medical record is a view where entries are grouped by clinical section. In other words, the record is first organized by these familiar headings. This kind of structure also enables generic overviews, such as dashboards. Because entries are consistently grouped, summaries can be generated automatically. The same applies to reporting. Structured sections make it much easier to create reports in a standardized way. Let's summarize. The electronic health record is organized into care encounters. In Solon's methodology, these care encounters are referred to as contacts. Each medical record entry is linked to the contact. Each medical record entry is also linked to a clinical section. Each medical record entry is also linked to an episode of care. Each episode of care takes its name from the most recent problem description or diagnosis label. How can the episode list and the diagnosis and problem list be derived? The episode list is generated automatically. It is a linear list of all episodes of care for the patient, meaning all recorded problems and diagnoses. By default, it shows the active episodes of care. Resolved episodes can be displayed using filters. The diagnosis and problem list provides a hierarchical view. It groups clinically related episodes, meaning problems or diagnoses. It can also include key entries from the past medical history and allergies. On the diagnosis and problem list, episodes are shown regardless whether they are active or resolved. Here is an example of a diagnosis and problem list. The main problems are shown as a numbered list. Under each main problem, related secondary problems are listed as intended items. For instance, coronary heart disease can have related conditions such as hypertension, heart failure, and a post-myocardial infarction. And diabetes can be linked to complications like neuropathy or nephropathy and to key results such as laboratory results. So this view gives a structured, clinically meaningful hierarchy rather than a flat list. With that, we have worked through the core elements of Solon's episode-oriented medical record. We have introduced the key building blocks and how they are linked together. From practical experience, this architecture can cover almost all requirements within a single coherent model. Many screens are essentially just different views of the same structured and linked medical records entries using filters and navigation. Many things can also be automated in the application logic layer. Let me use this example to make the episode concept really concrete. This is a patient presenting with an acute abdomen. As you know from clinical practice, this really stays within one single contact or one single setting. It usually starts in the emergency department. There may be initial contact for triage and first assessment, and then a second contact, for example, a senior review by the consultant in charge. Next, the patient is transferred to visceral surgery. Appendicitis is diagnosed. The patient then undergoes surgery. After a few days in hospital, follow-up continues in the hospital outpatient clinic. Later on, ongoing care is provided by the GP. Organizationally, there are many separate contacts across different departments. Temporarily, these contacts are spread over a period of time. But content-wise, they all belong to one health problem. That is exactly what the episode of care captures. It links all relevant care encounters and all related documentation to the same episode. And the episode name can evolve as the diagnosis becomes clearer. It may start as a symptom-based label and later become a specific diagnosis. Once the problem is dealt with, the episode is marked resolved. So the episode gives a current view of the clinical course from the first presentation through to resolution. As a result, both cost and quality become measurable in a meaningful way. At this point, it also helps to distinguish between a care encounter and an administrative encounter. In the emergency department, there are two separate contacts with healthcare professionals, for example, the initial assessment and then a senior review. However, both contacts belong to the same administrative encounter, meaning they are built under one administrative unit. With that, we now have the big picture of the episode-oriented medical record and its key elements. It provides an overarching, high-level organization of the electronic health record. This gives a clear framework for solution design and for modeling EHR content and workflows. Thank you very much for your attention. I hope this tutorial was useful and practical. If you have any questions, please feel free to get in touch with me.